ONtheGO podcast.
So we are welcomed by Professor Doornberg here in Groningen, northern part of the Netherlands, and he's an orthopedic trauma surgeon by trade, and enjoys the clinical applications of artificial intelligence in orthopedic and trauma surgery as his scientific hobby. He works at both the departments of orthopedic surgery as well as general trauma surgery at the University Medical Center in Groningen, and he specializes in fracture surgery. And last but not least, he's also a part-time youth goalkeeper trainer at the Green-White Club in the northern part of the Netherlands, FC Groningen. Welcome, Jap, to our virtual studio.
Thanks, Jari.
So, as mentioned in the last part of your introduction, you are a youth goalkeeper football trainer. This you do in your free time or your part-time time.
Yeah.
And tell us a little bit more about that.
Well, as many kids, many kids have a dream, and my dream was, of course, to become a professional soccer goalie. And I still have that dream a little bit, although I'm getting increasingly older, and chances are near to zero. But it's great to be on the pitch with the young goalies, very ambitious goalies, and to get in a completely new environment, a professional environment, but a completely new environment. And our oldest son is part of the Groningen goalkeepers school, so in the area, and therefore actually I followed him, and now it's a good excuse to be on the pitch together and doing something completely different than orthopedic surgery, and it's great fun. Yeah,
great. And so, how old are the kids that you're teaching?
They're between 10 and 15,
okay.
And that's a great age because they love what they're doing, and they're super ambitious and driven. So it's a great pastime next to the professional orthopedic stuff.
Yeah. And maybe also translating to your work, what are some challenges that you face when teaching these kids?
The only challenge is time. Time is a challenge. So finding the time to do it and to balance that with family and the hospital is challenge. But for the rest, I don't think there are many challenges because the guys are super ambitious and driven to become a professional goalie, like I had that dream years ago. So no challenges there.
Okay. Great. So we're not only here to talk about football. Obviously, we like that, but we're also here to talk about the future of artificial intelligence and machine learning in the field of orthopedics, traumatology, and orthoregeneration. Mouthful. But before we can start talking about that, I would like to know from you what you understand from the definition of artificial intelligence and machine learning as the expert.
Yeah, so I don't like definitions too much because there are about 120 definitions of AI depending on who you talk to. So I'd like to think about why why AI is attracting us all, why it's a hype, why do we want to apply it to our profession. And I think there are two big important whys. One is to basically take over tasks we find rudimentary and don't like ourselves as much, which is admin, of course.
Yeah.
And the other why, and that's a more academic, interesting why, is how machine learning and human intelligence, machine intelligence and human intelligence can amplify each other. Mm-hmm. And I think that's a great field of academic interest. So one hand is to take over tasks that are take over simple tasks, and there are many examples out there already currently, and the other is how human and machine intelligence amplify.
Yeah. And how is that currently being applied maybe by yourself, colleagues in daily clinical care?
Yeah. So the most easy example is the admin task. That's Gen AI and large language models in particular.
Yeah.
So we have GPT in our electronic medical records. And
ChatGPT, like the real ChatGPT.
No, you can't say ChatGPT because ChatGPT is the one that's open access, open source, and you cannot put patient data in ChatGPT.
Okay.
So it's a GPT, it's a transformer, but not the chat version, from daily use. So it's in a confined area, confined ecosystem, and so it's secured. That's also the downside, because you cannot train it on global data, because that's not because of privacy issues. But what we do in clinical practice, what we're now experimenting with, is you talk to a patient, the computer overhears your conversation. It's all structured in a note. Diabetes goes into medical history, metformin into meds, and that way you have the conversation, and at the end of the conversation you have the structured note. You can go through the structured note with your patient, and you don't have to type yourself. So that's the ultimate goal, and that application is called ambient listening. Pretty big in the US, and we're experimenting with it in Holland and outside the US at this point.
And it's already working.
It's working, and you have to, of course, refine it and adjust it, and the prompt engineers are making it better. But it's happening. So that's something you couldn't think of 2 years ago. But it's actually happening, and that dream of no more keyboards is actually going on now.
That's amazing.
But that's not super sexy or spectacular, but it's going to make our job, I think, much better, more fun, full attention to the patients. But I think the human intelligence and machine intelligence that amplify each other is obviously not in that field. I would say that's another field of AI.
And so maybe this is one particular example of how it's been applied in current systems. For example, this is a clinical application, but for example, some research examples that you could give, maybe some projects that you're working on right now with regards to AI and ML. What's something that's big or happening in orthopedic trauma care?
So something that's stupid simple and straightforward is, if you talk about wrist fractures, you want to offer patients with stable wrist fractures a cast, and offer patients with a non-stable wrist fracture surgery. And in Australia, we operated on 85% of patients. In Holland, we treat 85% of patients conservatively. So there's a big cultural difference in what you offer. But in general, an unstable fracture, you would like to offer surgery. But we as humans and as surgeons have a hard time predicting which one is stable versus unstable. And that's how machine and human intelligence may amplify. So something we're working on is to create a computer vision model, convolutional neural network, CNN, that predicts instability in a distal radius fracture. And still the doctor and the patient decide to opt for surgery or to opt for a cast. But you can facilitate that shared decision-making process with an algorithm. So, for example, if a 50-year-old lady has a 70% chance of having an unstable fracture, and she's eager to have surgery, that makes the decision a little bit easier. On the other hand, if she has a 20% chance of having an unstable fracture, in other words, have an 80% chance of having a stable fracture, then you have a different discussion with your patient. You can still opt for surgery and she can move earlier, but it's a different discussion. And that's how you can amplify our intelligence with the machine.
That's I think an example which also will bring us maybe to the future in 2040, because obviously you're already implementing these results step by step in daily care. Considering the projects that are currently ongoing, maybe not only your own projects, but where do you think the AI and ML will take us, both from a scientific point of view and a clinical point of view, in, for example, 2040?
Yes, so you're coming from or this interview comes from a regenerative background,
Yeah.
right? So a great example is what's currently been done with the UK data bank, where you try to predict the development of arthrosis, so degenerative, joint degeneration.
Yeah.
Not only from imaging, not only from patient characteristics, but also from genomics.
Yeah.
And that's a super interesting field to be part of. And so in 2040, it looks like you can predict who will go on to have either hip or knee arthrosis,
Yeah.
and who wouldn't, and predict that in the course of decades. And it looks like we will be able to do that, and that will alter the course of treatment, obviously. Yeah.
So that's something that will be maybe going on in 2040, that we'll be able to, for example, if you see a patient on the outpatient clinic who has just had an ACL tear, to, for example, foresee the future, that the chances of developing OA for that specific patient will be 30 or 60%. Is that something that we're working on, such individualized advices?
Yeah, and not only with patients who tear their ACL, but also in the general population, who because there are increasingly more data of patient. Sorry, I say patient cohorts, but that's not true. It's people.
Yeah.
So it's cohort data of people who do not enter the hospital as yet, and I think that's a great blind spot we have in our current practice. So we only see patients that actually enter the hospital, and then you're a patient. But I think the big step forward will be data from cohort data of the general population that is out there, and that will really enhance our understanding of what it actually is that trigger, for example, arthrosis, and also what determines why certain people, general population, enter the hospital, and why some people choose to deal with it or are asymptomatic despite a horrible radiograph.
And this is a project that's going on from the UK, as you mentioned. Is that something that you're collaborating with UK researchers, or?
Yeah, so the biobank example is from the UK, and that's done in both Austin as well as and the UK, coming from the Oxford group. What we're doing in Holland is the Rotterdam group has the World Coach Consortium, and that allows us to look at a large cohort data bank, and we have the same thing in Groningen, which is called Lifelines, and that's trying to understand what's happening with the population outside the hospital and how they advance to have arthrosis.
All right, and that's mainly from the population perspective that we're now considering, maybe shifting a little bit backwards to the patient population that you're also doing research on. For example, you mentioned the example of wrist fractures. Let's say in 2040, if we have a patient with either a hip fracture or a wrist fracture, what do you think the clinical care will look like from an AI, ML perspective, or glasses? What will be possible, what will be not possible, and what are maybe the downsides of AI in 2040?
Well, you talk about wrist fractures. That's something that's super common, and we still have a great variation in treatment. So I hope that in 2040 the variation in treatment will be less, because it doesn't really make sense why, depending on who you are and where you live, you get a sort of treatment. Hopefully we can do it much more individualized. Same thing with hip fractures, and that's coming from Holland. That's a little bit controversial globally, but as you probably know, in Holland we have the Frill Hip study, and that offers patients and their families a non-operative pathway based on comfort. If you have a short life expectancy, which is again controversial. When I was working in Australia, the Frill Hip study was going on in Holland, and it was very hard. It was very hard to sell why you would on earth offer non-operative treatment to a Frill elderly with a hip fracture. Machine learning can help you make that decision if the patient has a very short life expectancy. Again, for us humans, it's hard to predict death. So life expectancy, survival, and there are pretty good models now that can help you make that prediction. And if a patient is indeed has a very short life expectancy, is very frail, is not expected to live more than 3 months, or along those lines. This hip study shows that it's a very rewarding, but very good option for family and patient to not have surgery. Then the decision who lives longer than 3 months and who doesn't is challenging. So if a patient decides to live more than a year, then the non-operative option is not maybe the best one. And then again, the machine learning models that are out there can help you decide on the decision. So again, amplify human and machine intelligence to make those shared decisions.
And that's not only for I guess for the patient who is potentially frail, but also maybe for the non-frail patients, considering, for example, hip fractures in the future in 2040. What other targeted therapies, taking into account AI and ML, will be out there that besides decision making will help us? So some other examples or projects that you're working on.
Yeah, so the other decision, but that's something you're not referring to, is the between total hip and hemiarthroplasty. But so that decision can be augmented as well with AI. But you're talking about
in general, either indeed hemiarthroplasty versus total hip, or for example for the relatively younger patient with reduction internal fixation versus total hip. Are there some studies that you're working on, or some project that you're doing?
So exactly those studies. So you can decide for which patient the ORF is a better option, and joint replacement or joint replacement is a better option. I think if you're talking about 2040, that's so far away. If you talk about AI, so every half year the game changes already. I mean, 2 years ago, experts were talking about Gen AI, but now also all of a sudden it's coming good and it's already in practice within 2 years. That's amazing. That's a lot in research, but also in clinical application. So 2040 is we don't know what we don't know.
It's maybe too far yet to really see what's going to happen.
For sure. For sure. Nobody would even believe that the computer's overhearing your conversation and you get it scripted, structured, etc. 2 years ago, that was not. It was unbelievable.
And that maybe also brings us to the question I was referring to earlier. Now, computer overhearing maybe us or the patient writing down the whole story and the whole patient history. What do you think, maybe in the foreseeable future or in 2040, will be some dangers or some downsides of the application of AI and machine learning?
Yeah, so Elon Musk says that it's the greatest threat to humanity. So I don't really believe that. I think that's a great slogan to sell products. because it really triggers a lot of interest. No, so the biggest challenges is what people say is that if you can truly predict the course of an individual, let's say in the general population, that people will develop a certain disease, let's say cancer, then you get these really important debates of privacy. How are you going to deal with those predictions as an insurance company, as a society as a whole? So those are, if our predictions will become truly that accurate about how you will, if you will develop a certain disease and when, then you get these super important ethical discussions about what you want to know as an individual. Should society know? Should an insurer know? And how are you going to deal with those probabilities in your life? Do you want to know?
Something that I have to think about on my way home to Amsterdam a bit. But is it something that you're also working with regards to like the legal perspectives or maybe the ethical perspectives, doing collaboration with the ethical department to take into account also those factors?
Yes, we have an ELSA lab, and that's looking at both the ethical as well as the legal implications of such potential predictions. And that's a very important field, so we aim to collaborate with them. We don't aim to collaborate, but with every project we undertake, we aim to solicit their advice. So that's an important and big group. And whenever you are getting super enthusiastic about a new application or a new prediction model, or you have to think about those legal and ethical implications. Even the simple stuff as the computer overhearing your conversation. What are the legal aspects of that? Now you talk about potential complications of a surgery, so you consult the patient about potential complications of surgery. What if the patient says, well, you didn't consult me on that certain complication, and you can say, well, we have recording. So or vice versa. Or vice versa. So you can say, well, I may have not told the patient that with up to that detail, and then you have to record.
So that's something also to take into account when counseling patients and saving all the MP3 files or whatever files you're saving.
Are we going to save just the abstract of text, or are we going to save the complete conversation of any consult we have, and how are we going to deal with that? And the same thing is that you have the OR black box. That's another development. You've probably seen that. So if we're gonna put cameras in our theater and they're gonna record the complete procedures, that's gonna be hugely advantageous in terms of, for example, efficacy. So you don't have to count the gases, the lab count at the end of the procedure. Theoretically, that whole recording of the surgery will give you an op note at the end, so you don't have to write your operative note. All those things. But also, when something goes wrong, you can look back and learn, which is the good part. But it also has huge legal impact as well, because will a lawyer be allowed to look at the whole recording of a surgery? That's going to be super important ethically and legally if you start using those applications.
That's something that indeed to consider and take into account. Just trying to also slightly, because all these subjects are really interesting to talk about, slightly trying to get back to the overall theme, the orthoregenerative theme, and the combination with AI. Are there any ideas or projects that you're currently undertaking that you could maybe tell the listeners about that has some connections to orthoregeneration, like development of osteoarthritis, or maybe meniscal lesions or cartilage that's of your interest and that you want to research?
Yeah. So if of course I'm still in my field of interest and clinical practice. So if you talk about, for example, tibial toe fractures, um, with tibial toe fractures, the big question is who will develop arthrosis and will go on to have a total knee arthroplasty, or who will not, and will retain their own knee at least for, let's hope, for 20 or maybe 30 years. So if you talk about degeneration or regeneration, again, those prediction models can be important because we know that it's not only the quality of your reduction, and not only quality of your surgery, it's of course also of course soft tissue, so it's a trauma, but it's also the regeneration potential of your patient, which plays a factor. It's super multifactorial and challenging in that respect, and we only know just a little tip of the iceberg. Of course, if you screw up your reduction, that's one thing. But if you do a good job in your reduction and the trauma did not crash the cartilage to an amount that to an extent that there would not be a generation possible, then what other factors play a role? And then you're back to genomics again. So there are a few projects undertaken that look at those factors, and at this point, it's we know a few factors that are predictive of are additional predictors of post-traumatic arthrosis, of patients going on to arthrosis. But that's, if you talk about 2040 again, that will be much more elucidated than at this point. So we developed a few prediction models of patients going on to have a total knee arthroplasty, but they're at this point super stupid simple models that don't take as much of those potential predictors into account as yet.
So in that sense, the models will help us identify other factors that we're maybe currently not considering being of importance.
Yeah, the unknowns again. Yeah. And hopefully we can intervene and offer something else than just plates and screws and a good rehab regimen.
And that maybe comes down back to the genomics again, that there may be some kind of way to interfere, saying, okay, this patient is at risk because these are the genetic predispositions, and maybe the RNA that's being upregulated, and in that sense you could target that
exactly
for the future. But that's again
unknown.
Yeah, very far. Well, we've already gone quite deep into the application of AI and ML in the future, and I think the main takeaway is that maybe 2040 is too far away to really predict, but that we should think in steps of 2 years.
I'm afraid months with this speed. It's going so fast that I think every half year you can make a new podcast.
We'll come back in half a year. You've mentioned many projects that you're working on or collaborating with other partners on your quest for the future with regards to AI and ML. Maybe just a general question: where are you usually getting your inspiration from? How do you constantly keep up and come up with new innovative ideas? What's the secret?
Well, there's no secret. It's just the basis is still always the patient. Sounds a little bit corny, but your patient should be your inspiration. So whenever a patient has a question and you can't answer it, you try to come up with, or try to start to have a quest for the answers, and then you look at your peers. So there are so many smart people out there. You have many AI-driven labs that you can consult, and I think the key is to collaborate in a way that you, as a clinician, try to frame a good clinical question, And then hopefully, in our case, we have the luxury of a few very good AI labs, and then you pose your clinical question and try to find the answer with computer scientists, but also, as we just mentioned, with the ethical and legal frameworks. So you have a multidisciplinary team to try to answer the question. But the basis, and that's not a secret, it's just the corny truth is that your patient should be your drive, and the things that you see in clinic or that are discussed in the morning rounds, that should be the inspiration. That's plain and simple.
Yeah, and what you just mentioned as well with the multidisciplinary teamwork that's around the whole project. Maybe our listeners wouldn't know that, but for example, many people around you know that you've been in Australia, you've been in Boston, Amsterdam, and now you work here as professor in Groningen. How do you keep up, or how do you deal with keeping up the collaboration and keeping the connections warm and having everyone on the team and work it out so well? What's in that sense the way you do it?
That's again, I've been very lucky to work in different places with a lot of very curious people. So with people that really are driven by what they see in their daily practice. With the team in Amsterdam, but also with our hospital in Australia was right next to the Australian Institute of Machine Learning, and you just consult, or you walk into the AIML and talk about your clinical problem. And it takes a while for them to understand the clinical problem because they have a completely different background of computer scientists. So it requires training, rudimentary clinical training to understand the clinical problem, and vice versa. They have to be patient with us, being non-computer scientists, and that's building those bridges is super important, but also very valuable. And then you have to, if it's a mutual interest, then the rest will follow. So for the Australian example is important because we still have PhD students on the clinical side, and now recently also some PhD grants on the computer science side. And we really, and maybe that's a secret, we try to get those computer scientists into the operative theater or into our morning rounds. And then we speak a language they don't understand yet. And I think that's the fun part. To train a computer scientist that has no clinical experience whatsoever, and to show them some blood, and to show them a fracture and fracture patterns, and etc. And vice versa. They have a great AI lab, and try to for us to understand the basics of AI and our PhD students. And same thing in Boston. Both on the clinical side, there's great expertise, as well as on the AI side. And if you can talk both languages and build bridges between them, then that's great fun. But that also will advance us a little bit. So a great example is a orthopedic residence in the Harvard residency program, and she is also trained as a computer scientist. So she took a year off of a clinical training to work in an AI lab. And those people are super rare, but also super valuable to advance both of our fields.
So go out of your comfort zone and do something that you're not comfortable with, and then see if you can build a bridge between those two worlds. That's a good example, I think, for our listeners to get there.
If you talk about a secret, there are not many secrets, but maybe that is one of them. To basically drag those computer scientists into clinic and vice versa.
That's good to hear. That's a good example, and I think we'll keep that in mind. We're slowly getting to the end of the podcast, and I think some last few personal questions that we always close the podcast with is maybe the first one that I'd like to know from you is, if you think of one person, he or she could be dead or alive, that's out there, who would you still want to have a coffee with for an inspirational conversation?
Wow, that's a very challenging question.
You can say Arjen Robben.
He's alive and he's around the corner, and our sons played soccer together. So that's well, maybe it's always a recent thing, but I mean to say it will change every month probably. But what lately I've been talking about osteotomies a lot, and then plant osteotomies, and then there was a recent symposium, and then I was thinking about Professor Marty a lot, and Professor Marty is of course an inspirator for many generations of surgeons. A Swiss orthopedic surgeon who was the first to introduce plate and screws in Holland, and a legend. And he was also a big advocate of osteotomies, of the craft of osteotomies.
Yeah.
And he wrote in his book, Osteotomies Are a Lost Art, and he wrote that in 2009-ish, I think. So not even that long ago, 2006. Not even that long ago. And that's an AO book of post-traumatic deformities and osteotomies for post-traumatic deformities. And I think it will be fantastic for him to see what's happening now with 3D labs, with 3D plant osteotomies, and that it's becoming a craft again. And so I would say it's a lost. He said in the introduction of his book, it's lost art, and that's why he wrote the book. But I think you can argue that it's now current state of the art because of the new 3D planning technologies, patient-specific guides, repositioning guides, and I think that's becoming bigger and bigger now. And so that would be a nice cup of coffee to maybe show him in return what's going on now, and Back to the Future. Back to the Future. I think he would really enjoy that.
Yeah. Well, that's a great way to end the podcast for our listeners to look up Professor Marty and maybe look up the book, probably somewhere in some libraries that you can still find it.
Okay.
In this very library we can see it. So again, thank you very much for being our guest on the podcast, and we'll see it appear online very soon.
Thank you for coming all the way to Groningen and being here, and please enjoy our beautiful little town of Groningen this upcoming night.
I will.
Okay.
Thank you.
This was On The Go, the podcast on orthoregeneration. For more content, stay tuned at my.on-foundation.org. Thanks for listening and have a great day.